Recording in progress.
Good morning, everybody. We're going ahead and letting folks into our room and getting recording rights conferred. And Ashley and Meetha, can you let us know when you have accomplished that?
Absolutely.
Thank you. Thank you, everybody, for being with us today.
I think I am good. What about you, Ashley? Yeah, good on my end.
Okay, thank you, Meetha and Ashley, really appreciate it. And good morning to everybody who is joining us for this media briefing. Really appreciate you taking the time to do this with us. It's a really great way for us to get important information out to the community. My name is Taya Briley, and I am the Executive Vice President for the Washington State Hospital Association. And we have some great panelists here with us today. I want to welcome them. They are Dr. Danielle Zur, with the division, who's the division head for pediatric infectious diseases for Seattle Children's. Dr. Bob Peltz, infection prevention medical director for Peace Health. Susan Stacy, who is the chief executive for the Providence Inland Northwest Washington region and is also a nurse. And Dr. Jay Cook, who is the chief medical officer for Providence Regional Medical Center in Everett. So welcome to all of our panelists, and we're looking forward to hearing from them. I want to start out with some background for you all today. We usually start this briefing with an update on COVID-19, and we will for sure get to COVID-19 today, but we are going to start with a concerning report on hospital capacity. And the most remarkable part is that this problem is not being primarily driven by COVID. So right now, in this moment, our biggest concern is a severe lack of hospital capacity. Our hospitals are bursting at the seams. Several major hospitals and health systems are at or near 120% occupancy levels, but they are not filled with COVID-19 patients. Remarkably, they are filled with patients who do not need hospital care. And the severe shortage of hospital inpatient space is already delaying procedures that are vitally important to the health of our community members. For example, heart procedures or cancer surgeries are being delayed. It means that patients are receiving care in emergency department waiting rooms or in the hallways on gurneys and waiting for days for inpatient beds to open. We are concerned that a surge of COVID-19 patients could result in people dying, not because others with a desperate need of hospital care are taking up hospital space, but because non-acute patients who cannot be transferred out of the hospital are taking up hospital space. So you might want to know a little bit more about these patients and why we can't move them out of the hospital. They're patients who have complex long-term care needs, and a facility cannot be found due to staffing shortages or the inability to care for folks with these complex needs. They are people who are waiting through the very long process of evaluation and placement by the state Medicaid program and managed care plans. It can be a long process. Hospitals operate in hours and days, and that process can operate in weeks and months. They are patients who could get a room in a post-hospital facility, but they don't have a family member who's authorized to consent to placement. State law for family consent to long-term care placement is remarkably complex. They are adolescents and adults who are in need of inpatient mental health treatment, but there isn't an inpatient bed for them to go to. If we were able to move these patients out, we would not have to delay procedures, and we would have a lot more confidence about handling a COVID-19 surge. We are concerned that a surge of hospitalizations from the Omicron variant on top of an already crowded set of hospitals could lead to a situation where life-saving hospital care is denied to those who need it. And this is ironic because the patients who are in the hospital taking up the beds don't need acute care at all. Washington is working with long-term care partners and urging the state to implement solutions that we know will work in this crisis. This is a situation where the steps that need to be taken are simpler to identify than the process of actually making those steps happen. One thing that we're doing is advocating for legislation to smooth the consent process to move patients who are stuck in the hospital to long-term care. Right now, a complex, expensive, and court-intensive guardianship process is required. We think that existing state law that allows for designated family members to consent to healthcare makes much more sense and would be a lot more humane for these patients who don't need to stay in the hospital. We are also strongly encouraging the deployment of state resources to complete patient evaluations faster and streamlining those evaluations to move patients to long-term care services. And we're encouraging higher payment rates for long-term care facilities so that they can pay more staff to deliver care in those settings. So we wanted to start with what really is top of mind for our hospitals and health systems this morning and at this time. And now I want to turn to the COVID-19 numbers. So there was an average of 654 confirmed COVID hospitalizations this past week compared to the prior week's average of 652. The numbers remain flat, which is good, since we have seen a slight uptick in those numbers after the Thanksgiving holiday week. And it's interesting to reflect that this time last year, we had an average of 1,150 COVID hospitalizations per day. We are right now we are averaging 116 new hospitalizations each day and roughly 25 to 30 COVID deaths. The numbers right now are a lot lower compared to last year, averaging 67 new hospitalizations per day. We're seeing a sustained high number of patients on ventilators and an average of 12 to 20 COVID deaths per day. And it is sobering to think about the trends that are driving this stubbornly high number of deaths. And it is almost certainly from patients who were sick with COVID during our last surge and have been on ventilators for weeks, a very extended period of time, and are just now succumbing to the disease. So very sobering that our death rate continues to be higher like that. I want to return to some factors that could limit hospital care, and one of those is staffing. Like many industries, healthcare, including hospitals, is experiencing the effects of short staffing. And while the overcapacity issues that I discussed at the beginning of the briefing are one limiting factor to accessing healthcare, limited staffing is another concern. And for many years, hospitals and health systems faced staffing shortages in highly skilled areas like registered nurses, physicians, and some specialized technologists. And the national healthcare workforce shortages were exacerbated by the pandemic. Loss of staff to burnout and retirements and higher wages that can be earned as a traveler instead of as staff nurses or staff workers are some of the factors that have been driving the need for increased staffing across the country. We're seeing that more workers want to work part-time. That means we will need more workers to fill full-time positions that hospitals have. And speaking specifically to nurses, we are fortunate that in Washington State, we are a highly desirable place for nurses to work, and yet we still have nurse shortages. Washington frequently appears on the best states for nurses to work based on pay, benefits, and quality of life. And most recently, Washington State was ranked 6th in the nation for highest nurse pay, Even California, which is ranked #1, continues to struggle with nurse staffing shortages. Washington has a progressive nurse staffing model that engages frontline staff in developing staffing plans. So as we're facing these nurse staffing shortages, we are fortunate to be in a place where we already have some benefits in terms of being able to recruit and folks into the profession and to work in our state. We have been supporting nurses with things like retention bonuses and increases in base wages, the opportunity for differentials for additional shifts. We've been providing daycare, meals, mental health counseling, and other supports in many of our hospitals. And hospitals, the Hospital Association, and other partners are invested in building the workforce. Our efforts include pursuing increases in state funding for education and pay for instructors, individual hospital and health system support for clinical placements and local training programs, innovative approaches in partnership with local community colleges, and contributions to education and training funds that are maintained by worker unions. And we hope that with these short and long-term solutions to mitigate these staff shortages, we also ask our community members to do everything they can to stay healthy and don't burn out our workers by becoming unnecessarily sick. We know that caring for COVID patients is exhausting. It's very intensive, laborsome work. And it is also frustrating for workers who are caring for largely folks who are unvaccinated, which are the individuals in our community that really are those who are needing hospital care. Okay, next I want to talk a little bit about the Omicron and Delta variants. There is a lot of attention focused right now on Omicron, and rightly so. And like all of you, we are reaching out to learn everything that we can about how it might play out in our country by looking to other countries. And we know that the absolute best way to prepare for Omicron is to get vaccinated and get your booster shot. Not only are adults now eligible for boosters, all of them, but also those who are 16 and up, who just were approved for Pfizer boosters, those in that 16 to 18-year-old range. And we are also so thrilled to see the number of vaccinated children ages 5 and up climbing. We know that many families are also anxiously awaiting getting vaccines for what I call the littlest of the littles. Pfizer is collecting data in a cohort of kids that are ages 6 months to 2 years, and they are running a study and collecting data on another cohort between the ages of 2 and 5. And they expect that they will have data at the end of this month or the beginning of next. And from there, they could begin seeking approval for the vaccine for those age groups. And we know the worry right now is about what Omicron might do, but need to stress that it is important to remember that we don't need for Omicron to show up before we can start protecting ourselves. And to note that the Delta variant of COVID is still in the community and it is dangerous and is making folks sick. People can continue to do all of the things to prepare for Omicron that they can also do to protect themselves from Delta, which includes vaccinating and masking and taking social distancing measures as directed by public health. And again, we really encourage folks to get vaccinated. That's the best thing that they can do to protect themselves and the rest of their community members and loved ones. And I just want to close with a note on mental health. As I noted above, one of the factors that are adding to the overcapacity of hospitals is an increase in the number of individuals, both adolescents and adults, who need inpatient mental health treatment. Please continue to be vigilant about your own mental health and that of your loved ones, and reach out to your healthcare provider early as soon as you start experiencing symptoms, and try to get ahead of the issues before mental health needs escalate. So I will go ahead and end my remarks there, and I want to go ahead and turn this over to our panelists. So I will go ahead and ask for Dr. Zur to be able to give some remarks here. Dr. Zur, I'll turn it over to you.
Good morning, everybody. At Seattle Children's, we've seen a decrease in our new positive daily case rates, as well as our hospitalizations due to COVID-19. Our positive test rate at this point is about 1%, and our total number of children who are hospitalized on any given day with COVID-19 ranges between 2 and 5 most of the time. That's quite a bit lower than our peak in August and September. So we're glad to see that. Despite our COVID numbers coming down, however, our hospital census and our emergency department census remain very high, and our staffing remains tight. So this is clearly not due to COVID-19. We're seeing a lot of other respiratory viruses. We've had a robust RSV season, and we're still seeing a high rate of RSV in our kids. In addition, a lot of behavioral health visits, both to the emergency department, and some of those kids are having to be boarded in the emergency department for prolonged periods of time, which is really unfortunate. To try to mitigate that issue, Seattle Children's has developed a behavioral health crisis care clinic that is geared towards helping those kids who are having urgent issues but not emergent issues. And the idea is to provide a short-term series of outpatient visits to try to help support kids and get them back on track until longer-term outpatient resources can be established. The good news in terms of COVID-19 is boosters are now available for the 16 and 17-year-olds, and it's recommended that teenagers pursue booster shots or families pursue booster shots. In addition, as already mentioned, the Pfizer studies of the youngest age group are ongoing. We're hoping to have early data at the end of this month or the following month, and then we'll hopefully see approval either by the first or second quarter of 2022. So we'll continue to watch that. I think that's all I have, but happy to take questions when the time comes. Thank you.
Great, thank you, Dr. Zur. And next, I'll turn it over to Dr. Pels.
Hi, thanks for having me. I'm an infectious diseases doc and actually in Eugene or Springfield, Oregon, but I'm medical director for the infection prevention for Peace Health, which has 5 hospitals in Washington State. I think we've faced a lot of the same challenges that every other hospital around the state has faced. We've come down, fortunately, from the peaks that we were seeing with the Delta surge, but unfortunately, we haven't really hit the bottoms that we've seen with other waves of COVID, and we're sort of stuck at a fairly steady level of COVID. You know, we're not having to cancel surgeries, but like you mentioned, we continue to struggle with hospital capacity issues, which are a chronic problem even before COVID ever happened. We're, you know, in the 90+% capacity at most of our hospitals currently. We do continue to struggle with boarding people in the emergency room because there are no beds available, which is in turn, of course, is because you can't get people out of the hospital. We continue to see COVID come into the hospital. For the most part, it's people that have not been vaccinated. About 15 to 20% of our COVID inpatients are people that have been vaccinated, but they almost never need ICU care, and deaths are very uncommon in the vaccinated population. We've had 2 people so far that have had their booster vaccine that have been hospitalized. But other than that, really, you know, as everybody else is seeing, the majority of the hospitalized patients that we're seeing with COVID are completely unvaccinated. And like everybody, we continue to struggle with the constant whack-a-mole issues of supply chain problems that pop up in areas that you really wouldn't expect. And meeting our staffing needs is challenging and very expensive. I think that's about all I've got to say. I'll be happy to take questions at the end. Thanks.
Okay, great, thank you. And for those of you who do have questions, please feel free to chat them in and we'll get them to our panelists. And we'll open up you to ask questions as well when we're through our panelists here. So from here, let's go ahead and move to Susan Stacy.
Good morning. Thank you for having me here today. So much like you've heard before, in Spokane and Stevens County, we are too seeing a slow but steady drop in our COVID numbers. We do continue to see that our sickest patients, especially those in the ICU, are our unvaccinated population. But nonetheless, the numbers are encouraging at this point in time, and we're pleased with that. We do, however, as we get our hopes up, as things start to look better and as our beds are opening up from fewer COVID patients, we don't always have the staff to take care of everyone else who is needing health care. We've returned to surgeries, and that buildup's been very good, because these are important surgeries. People have been waiting a long time to see the surgical volumes start to go up and get much needed surgeries. But we're watching it very closely as we try to get our capacity back in shape that's really being limited at this point in time by staffing, which is a significant issue. I've been a nurse for 38 years, and I've not seen a staffing challenge as difficult as it's been in my career, with many patients needing our services, and we are doing everything we can to build up our staffing along the way. One of the things that Taya brought up, and my colleague from Everett is going to speak a little more about it later, is really the issue around our patients who are sitting in our acute care facilities who don't require acute care service. We've had some success in our long length of stay patients, as we have recently had a new facility open up around in Spokane, not a Providence entity, but one where we lease space to a facility, and we're really encouraged by this development. And it too has been helpful, but it is a slow increase of their ability to take patients because of their staffing. The staffing issues that exist in our facilities are replicated in long-term care, and that's really contributing to this bottleneck of getting patients out of acute care so we can get more patients into acute care. In terms of staffing, both retention and recruitment, I really believe there's a tremendous amount of energy at our hospitals, in our human resources teams, in our schools to really pull together to recruit and retain staff. We are also embarking on several Earn While You Learn programs, recognizing that sometimes the path to get into healthcare means we need to create a path of employment while one's in school to really get ahead of this as a longer term strategy. So finally, my last comments is really around our caregiver and our staff morale. It's difficult right now. As the holidays approach, we're of course concerned with an increased spread of the virus, whether it's Delta or Omicron. But we've experienced so much loss over the last couple of years, and we are offering a lot of mental health resources for caregivers, including an on-site counselor and virtual sessions and more, but people are tired. And so as we head into our holiday season, I would just ask that we stay vigilant. Even those that are vaccinated, stay vigilant around enjoying the holidays in a responsible way to help keep our volumes down of COVID patients in the hospital. Thank you so much.
All right, thank you, Susan. And from here, I'd like to turn it over to Dr. Cook.
Good morning, everybody. My name is Jay Cook. I'm the Chief Medical Officer at Providence Regional Medical Center, Everett. It's good to be with you. Since last summer, our inpatient census has frequently bumped up against and sometimes has exceeded our maximum licensed bed capacity at our acute care Colby campus. This is despite our COVID census remaining pretty steady over the past couple of months at about 40 to 50 patients. Some of our high inpatient volume is due to the high demand for the acute care services we provide to the North Puget Sound region. Excuse me, but a large part of our high inpatient census is driven, as others have said, to the large number of patients who remain in our hospital without an ongoing medical need for acute inpatient care. Currently, we have about 100 such patients, and that represents 1 out of every 6 beds in our hospital. And we're having difficulty finding outpatient care facilities to assume their ongoing life needs. Many have severe dementia or other challenging behavioral conditions. Some have complex psychosocial, financial, or other barriers. Our problem is that these vulnerable but not acutely ill individuals occupy inpatient beds and require the same limited hospital staffing needed for other patients with more severe acute medical problems that need our care. Like most healthcare facilities across the US and some of the panelists you've heard already, Providence Everett is facing significant staffing challenges in almost all inpatient departments, including nursing, lab, environmental services, and transport. Our staffing challenge is made worse by needing to provide an inpatient level of care for the high number of patients who have no ongoing medical reason for being in the hospital. This combination of high hospital census and limited staffing requires that we allocate limited resources to existing inpatients and defer services for less time-sensitive medical conditions. Last week alone, we postponed more than 40 non-emergency but medically necessary surgical cases. Our team works really hard to get these cases rescheduled as soon as possible. But in the meantime, patients and their families face the emotional and physical stress of having to wait for their procedure or service. For example, last week, patients had to wait for a delayed heart valve replacement and for removal of cancerous tumors involving the colon. This problem, as you've heard, is not unique to Prov Everett. Our colleagues in many other hospitals around the state have needed to sometimes limit these kinds of key services for the very same reasons. Making these difficult decisions about who can receive these services and who cannot adds to the moral distress of our hospital staff, who we desperately need to retain for their skills and experience in caring for the most acutely ill patients in our communities. That's why it's critical that we find solutions and resources to free up hospital staff and beds to care for people with the most acute medical needs. Recently, the New York National Guard deployed 120 Army medics and Air Force medical technicians to 12 nursing homes and long-term care facilities across the state to ease staffing shortages there, allow for patients to be discharged to allow the acute care hospitals to function, providing the services that they are prepared to do. We need similar funding and staffing supports in Washington, both at the state and the federal levels. I really appreciate the opportunity to share this information with you today, and I'm happy to try to answer whatever questions you might have.
Thank you very much, Dr. Cook. And I think that's such a good point that you make about the stress of not being able to get folks in for scheduled procedures and having to decide who needs to experience those delays. That's not something that any caregiver wants to be in the position of needing to do. We do have some questions that are coming in, and I want to go ahead and start with the first one, which is, are there numbers that represent what the nursing shortage looks like in the state? What is driving the shortage? Is it burnout? And we did survey hospitals not long ago, and so want to share with you the results about what is driving some of these decisions on the part of folks to leave the profession, or at least leave their positions, if not the profession. So interestingly, one of the top reasons was relocation for a spouse's position, also that spouse moving. But very significantly right behind it was leaving to be a traveler. So travelers are individuals who work for agencies, and the agencies place those staff in places where there are staffing shortages or a need for staff. And one of the trends that we are seeing is nurses especially leaving their regular hospital employer and going to agencies because they can make more money being deployed as an agency nurse. From there, we see retirement and yes, burnout, which is absolutely a factor, if not the largest factor. So I wanted to share some of those findings from our survey with all of you. And the next question that we have is for Dr. Zur. And the question is, with regard to the behavioral health crisis you're seeing among youth, can you elaborate on some of the factors that are driving that situation?
I'd love to elaborate, but I know that there are others at Seattle Children's who could better do that. So I'm sorry, but I could find somebody to connect with you offline.
Okay, thank you, Dr. Zur. And we have another question here. Is there any sort of timeline for the legislative action and state requests related to discharging patients to long-term care facilities? When can we expect another update? We would love to keep you updated on this. It is a top priority for the Hospital Association and its hospital members. The state legislature convenes in January, and we hope through our work with our partners at the state and with our legislative partners, we will see some legislation advance during the session that will improve the decision-making process to be able to move these patients faster into care settings. One of the, I guess I'd say a source of frustration for those who are at the bedside trying to get these patients moved into long-term care settings is that the decision-making process for moving into a long-term care setting actually has this requirement oftentimes that involves a guardianship process, whereas for healthcare decision-making, there is a process in law that allows for identification of a decision maker that allows consents to things like surgeries that is less ridden with barriers than the court process for guardianship. So I think the perspective is if the statutory process that is in place for folks to be able to consent to surgery is sufficient for consenting to surgery, why does there need to be a more intensive and barrier rich, I guess I'd say, situation for those that are needing to be discharged to long-term care? So we will for sure keep you updated, and thank you very much for the question. It's a complicated issue and it is really important in terms of keeping our acute care facilities free to provide hospital care. The next question or comment is that a national report just named Washington State without adequate long-term care staffing, a problem that has only gotten worse during the pandemic. What kind of plans are in place to help staff up our long-term care facilities? So I will give a short answer, and then I want to have one of our staffers, Zosha Stanley, also speak to this. So one of the things that the Hospital Association is really encouraging is increased payment rates to nursing homes that in turn can be translated to higher wages for those who work in nursing homes. Nursing home care is challenging, it's labor intensive, and for those staff who work there, they may be able to find positions that pay more and are less labor intensive in terms of the physical work of taking care of patients. So with that as a little bit of intro, I want to have Zosha speak to some of the other steps that are being taken.
Yeah, thanks, Taya. I'm Zosha Stanley. I'm the Vice President and Associate General Counsel here at the Hospital Association. And I want to emphasize Taya's points about the reimbursement rate, especially for the Medicaid rates. We know that those have been those don't cover the costs, and they don't allow the long-term care facilities to pay their staff in a way that's sustainable. So we are supportive of long-term care proposals to increase those rates. The other piece is, we talk to the long-term care facility folks, and they say, when we say hospital challenges, that we don't have enough workforce, and we're at these huge capacity levels, as was already mentioned, and our workforce is really strained. And the long-term care facilities say that, their version of that challenge is that some of their facilities are half full or, nowhere near a sustainable level because they don't have the staff to accept patients. So it ties back to that difficult to discharge, long length of stay issue Taya started with. The whole healthcare system has to work in order for any part of it to work. And the throughput from acute care to long-term care to, home with supports has to work. And so those staffing challenges are across the healthcare system, and we are continuing to partner with all the different pieces in the legislature to find the ways forward. So I'll stop there. Thanks, Taya.
All right, thank you very much, Sosha. Okay, our next question is, it sounded like Dr. Cook was describing operating under crisis standards of care at Providence Everett. Just wanted to make sure that's correct. I want to be clear that we are not operating at crisis standards of care. Crisis standards of care really are a situation where life-saving care, like a ventilator, for example, or an ICU bed, is being denied to a patient and given to another patient. It is being actively rationed. What Dr. Cook is describing at Providence Everett is delayed care. People are still receiving the care that they need. And Washington hospitals have made a unique in the country agreement, or at least it was unique when it started. I think some other states have followed our path, which is to agree that no hospital will go to crisis standards alone, that hospitals will go together if they need to go. And our state Department of Health has also made it very clear that crisis standards will not be invoked unless it is on a statewide basis. So with that, I will turn it over to Dr. Cook, who may want to make some more comments.
Yeah, thank you, Taya. And yeah, it's very clear that we are not operating under crisis standards. Crisis standards can only be invoked by the governor's office or the Department of Health. And we are managing our census very actively. And as Taya mentioned, we are deferring care. Our teams are able to get these rescheduled in a timely fashion, but it does, making these decisions and delaying care. I mean, I wanted to emphasize there is a cost to that for patients and their families, and we're working hard to minimize or eliminate whatever adverse outcomes may be, but it is a juggling act, and we're not alone. I know other hospitals around the Puget Sound area are in the same boat. And so far we've been able to manage, but as others have said, another big COVID surge or other disruption, it's, it can be sometimes tenuous.
Great, thank you. Yes, and I think that's an important point. We are not operating in crisis standards. We are also not operating in a way that is best for patients. People should be receiving their procedures, their heart valves, their cancer surgeries when they need to receive them, not on a delayed basis. So with that, I want to turn to Graham Johnson, who has his hand raised.
Hi, good morning, and thanks so much for this. I have a question about nurses becoming travelers, leaving their hospital staff jobs. I'm curious how often they are placed back in those same hospitals. So I'm kind of wondering if there is a net decrease in the number of nurses you're seeing in your facility, nurses either working on staff or there as travelers. And I'm curious too if there are opportunities to change the model and pay nurses more to make these traveling gigs less attractive.
Yeah, that's such a good question. And I definitely want Susan Stacy to be able to respond. And I will just say it is not unheard of for nurses to go back to the facility in which they originated. Maybe Susan can give us a sense of how common it is. I just want to note, though, that nurses are already in Washington State paid at some of the highest rates in the country. This has been a challenge nationwide. The agency costs can be a real source of frustration for those nurses who remain employed at their facilities. They may be working alongside those who are making a lot more, and Susan can maybe speak to this. It is one of the things that we think about when we talk about escalating healthcare costs. Staff is probably one of the biggest components of healthcare costs. So if we are thinking about being able to manage healthcare costs, driving up the cost of staffing is one of the challenges that we need to try and balance. So with that, I'll have Susan talk more to your specific question about how often do folks sort of do that flip of going from their facility to an agency, coming back, and any other insights she might have.
Thank you. So it does happen now in Eastern Washington. It happens far less, and we try hard not to have folks come back into the facility because it does create a tension and further decreases morale of our caregivers. Those folks who go to a traveling agency typically are younger, more mobile. They are folks who are more interested in the financial gain as opposed to the stability and those pieces. But traveling has always been an option. It's always been done. It has changed dramatically over the last couple of years with COVID and rates that frankly are unsustainable in a healthcare setting. And as much as Taya said, if we're going to keep the cost of healthcare to a reasonable cost, which impacts our consumers and our ability for people to get healthcare, we have got to manage that. Labor is our number one cost, and we have to manage our labor costs over the long run while respecting that the labor market has changed. And this is a balancing act that we're all working towards. And I think over the next several months and couple of years, we will see adjustments in that.
Thank you, Susan. I want to see if we've got any more questions coming in by the chat. I don't see any. My Zoom screen changed. Okay, we've got, so I'm trying to find the chat. Okay, looks like we have a comment here from Dr. Cook. Would you like to make a follow-up comment, please do?
Yeah, thank you. So I wanted to just make clear when I was discussing those procedures that we have had to delay. These are cases that you would consider elective, meaning they are not urgent or emergency cases. All the urgent and emergency things that are immediately necessary to preserve life, limb, or some critical outcome, we continue to be able to do. These are patients who, are put on the schedule as an elective procedure and can be deferred without expectation that their medical outcome will be in any way harmed. Although again, the mental and sometimes physical discomfort or condition remains until we're able to get it done.
Thank you for that clarification. Okay, and you're getting thanks from our media members as well. Any other questions that folks have that you'd like to ask or chat to us? Okay, I am not seeing any. I will ask our panelists, do you have any other messages or perspective you'd like to convey here today? Okay.
Well, I'll just say very briefly, thank you for the opportunity to, give this information. I think it's really important for the public to understand the situation that we're facing in the healthcare world. Everyone has been at this for a long time. It's been almost 2 years now. Our teams are getting fatigued. We're lucky in healthcare because people get into this because they want to help people, and I think that underlying motivation is really what has kept us going through all of this, and I think it'll be the thing that brings us through on the other side. But it has just been a very challenging couple of years, and they keep coming. Again, I would emphasize the need to get vaccinated, continue to do the ongoing public health measures needed to keep COVID at bay. And then again, we need some help with the patients who have to remain in our hospital because they don't have resources in the community to safely transfer out. So thank you.
All right, thank you very much, Dr. Cook. And like Dr. Cook, I would like to thank everyone who joined us today. It is incredibly powerful to be able to, through you, convey some of these messages to our community. And we will plan to see you all again on January 10th. And again, thank you, and hope you all have a safe holiday season. And do all the things we talked about doing today so that it can stay that way. And thank you very much to all of our panelists for joining as well. It's an important investment of doctor and nurse time, leader time, and it is a good investment to make. So thank you, everybody.